Neck and back pain is the #1 reason patients seek medical help. According to the National Institute of Health, 40% of all patients seeking medical help do so because of pain. Worse still is that 43% of pain patients develop chronic symptoms and 50 to 80% of spine surgeries fail, which drastically increases the overall cost. Physicians tend to blame the inadequacy of treatments, but the evidence overwhelmingly casts blame on the inability of conventional diagnostic methods to determine which nerve is causing pain. The Massachusetts Hospital Handbook of Pain Management states that history and physical examination have a limited role in the diagnosis of back and neck pain, but are important in ruling out serious pathology.
Physicians have used the neurological exam to try to narrow down the problem in terms of the nerve root. If there is a radiculopathy, the problem could overlap over a number of dermatomes, and the physician could guess wrong in terms of the specific nerve root that's the culprit.
The reason for misdirection is no secret. The answer is found in the physiology of pain itself. Two types of nerve fibers transmit pain: the fast pain A delta fibers and the slow pain C fibers. Over 90% of fast pain A delta fibers reach the sensory cortex of the brain, giving the patient detailed point-to-point discrimination in localizing pain. But less than 10% of slow pain C fibers reach the sensory cortex. Within 72 hours of injury, the fast pain fibers downregulate, while the C fibers continue functioning and can even upregulate. Since the C fibers are so poor at localizing the source of pain, the result is that 50% of patients are wrong when they tell their doctor where the pain is located. The textbook Neurology for Non-Neurologists says that EMG/NCV in neck, shoulder, and low back pain in the absence of motor deficit is costly, time-consuming, and seldom benefits the patient. Keep in mind that 40% of all patients seeking medical consultation do so because they have pain, and at least 95% of these pain patients have no symptoms of muscle weakness. EMG is performed by stimulating a large motor nerve going to a muscle and measuring the reaction of the muscle. If the muscle response is abnormal, the question then is the pathology in the nerve or the muscle? NCV rules in or out the nerve. This is done by testing the speed of a signal passing along the nerve. If there is enough gross myelin sheath degeneration or damage, the speed slows and proves the problem is in the nerve. If the conduction speed is normal, then either the nerve has not degenerated enough or the problem is muscle disease. Or the test is a false positive, which happens in about 10 to 15% of tests. The preganglionic dorsal nerve root A delta and C pain fibers are vulnerable to both disc bulging from the anterior, which pushes the delicate fibers back against the posterior ring of the spinal canal, and they are also vulnerable to swelling of the facet joints, which directly cause mechanical pressure and inflammation. But neither EMG nor NCV can test the small pain C or A delta fibers, and the anatomical location of these fibers makes them inaccessible to EMG and NCV testing.
I think that this is well documented even in the British Journal of Neurosurgery in 2002 when Johnson reported the sensitivity of MRI and cervical radiculopathy at 93%, whereas the sensitivity of using EMG nerve conduction studies in those same patients only had a sensitivity of 42%.
Diagnostic imaging, such as X-ray and MRI, reveal anatomical abnormalities, but do not prove abnormal nerve function. The New England Journal of Medicine published a study that shows MRI disc bulges or protrusions in people with low back pain are frequently coincidental. Out of 98 asymptomatic subjects, 52% had bulging discs at least one level, and 38% had abnormal discs at more than one level. The good news is that small pain fiber NCS offers a painless, quick, simple test the doctor or his nurse can perform in about 15 minutes that has sensitivity approaching 100%. The potentiometer electrode is placed on the patient's spine. A ground sponge is soaked with water and placed under the patient. The test probe is fitted with the end of a cotton swab and dipped in saline. The test follows a chart of standardized test sites which correlate with specific peripheral nerves associated with specific nerve roots. Each of these sites is tested by holding the electrode steadily against the site and turning up the dial incrementally until the nerve has fired, as verified by the patient and the potentiometer. The patient is his own control, so accuracy approaches 100%, as compared to tests where findings are compared to population averages on a bell-shaped curve. No averaging is required. The data is entered into the software for analysis, and the report is automatically generated. How does pain fiber NCS locate nerve pathology? Remember that A delta fibers always downregulate following injury. In layman's language, they become numb. This makes the A delta fibers the perfect marker to detect which nerve is injured. Because they become numb, they therefore require a much stronger stimulus for them to fire. The nerve requiring the greatest voltage amplitude to cause an action potential, a nerve impulse, identifies the injured nerve. The amplitude number from the dial is entered into the software for analysis. The graph displays the left and right readings of each nerve root horizontally across the grid. The higher readings on the graph represent the nerves that required more voltage stimulus to fire. Although surrounding nerves may be affected, the highest is the pathology. Pain fiber NCS can quickly localize the site of injury. For example, the C6, C7 nerve roots are the origin of both the radial nerve and median nerve. So, if the radial nerve in the back of the hand is normal, while the nerves in the thumb, index, middle, or half the ring finger are abnormal, the problem can only be in the wrist. The ulnar nerve is similar. Testing above and below the medial elbow allows detection of cubital tunnel entrapment. The report shows the significant findings. The diagnostic summary is quite generic and can be edited by the doctor with information specific to the patient. The reader is given the basic importance of findings and what they can mean.
I must admit, when I first looked at devices looking at pregangliotic fibers, I was skeptical. I was quite pleased after the first several weeks after using the device that the results were quite reliable, reproducible, and extremely accurate.
We had the device demonstrated in our clinic here at LSU, and we were impressed. We were impressed not only with the way it was able to diagnose problems on our patients, but we had some of our staff with problems too that were diagnosed. So after that initial exposure to it, we used it on a trial basis for a few months, and our impressions were warranted. It was a great device, and we kept it. We now use it on all our patients.
The biggest thing I've noticed that how this machine has helped and made a difference in my practice is if and when it's appropriate to do the injection medication, what level it's most appropriate to do. Especially in those cases where the patient comes in with symptomatology on one side, but the exam lights up a nerve that's hot on the opposite side, and inject the opposite side of the pain, and the pain goes away, and they get better.
Clearly, that's the raison d'etre of this test. I mean, you're going to be able to tell where the pain is all the time instead of just 75% of the time.
NCS just did an outstanding job of picking up 141 out of 149 abnormal nerve root examinations. And frankly, I think that NCS is the gold standard now, because I believe the epiduralgram may not pick up some pathology that an NCS will. NCS is functional, whereas the epiduralgram is an anatomical evaluation.
She has scoliosis and has had back pain ever since she can remember, in her 30s or so, 20s or 30s. There is no way with scoliosis that you can look at an MRI and say, well, I think this one is the most probable site of your pathology. But her obviously hot regions are left S1, left L2, and right L5. And she got off the table saying, this is the first time in 40 years that my back pain's been totally gone.
This device has actually replaced the use of EMG and nerve conduction studies in my practice, except under unusual conditions. This device, in my experience, is much more accurate, much more sensitive in the diagnosis of radiculopathy.